Let's say you're sitting in your OPD and a 32-year-old man presents with progressive ascending weakness of all four limbs since 4 days, preceded by tingling and numbness in the feet, which begin at the toes and fingers and spread proximally. There's no sensory level bowel and bladder involvement, but he has a history of diarrhea 2 weeks back. Neurological examination revealed quadriparesis, areflexia, hypotonia, and mild bilateral lower motor neuron type facial nerve weakness. Uh, you might think of the diagnosis of Guillain-Barré syndrome. Let's see what this syndrome actually is. Guillain-Barré syndrome, or GBS, is a heterogeneous immune-mediated condition causing demyelinating peripheral neuropathy. It causes life-threatening respiratory paralysis and is progressive and fast onset. Now, few characteristics of this condition are the acute paralysis progressing over days or week, and also the loss of tendon reflexes. The inflammation and demyelination of nerve roots and peripheral nerves is also seen, which is termed as radiculoneuropathy. It is a type 4 hypersensitivity, though it can also be argued it's type 2, but type 4 is the most accepted. The most characteristic pathological feature is the segmental demyelination, which is seen here. Though other pathological features could also include axonal damage and early changes that affect myelin sheath can also be seen through electron microscopy. Now, etiology. Most common is the Campylobacter jejuni causing dysentery, and the patient will say that he has a history of infection before few days, which got completely cured. The pathogenesis also works like that only, where after these infections antibodies are formed which start attacking the neuronal cell, which we'll see in few seconds. Other infections like CMV, EBV, herpes virus, mycoplasma pneumoniae, COVID-19, Zika virus, hepatitis E can also cause GBS, while vaccinations for swine flu, influenza, and the older vaccines for rabies, which were based on neuronal vaccines, can cause GBS. It is also more commonly found in individuals with lymphoma, HIV, or SLE. Now, there are variants of GBS which are acute inflammatory demyelinating polyneuropathy AIDP, which primarily affects adults and is the most common form in Western countries. The antibodies here involved are anti-GM1 type antibodies, which cause demyelination, and the pathology is there's initial damage occurs on Schwann cell surfaces, leading to extensive myelin injury and involves activation of macrophages and lymphocytes. Axonal damage may occur secondarily. Then acute motor axonal neuropathy, which is AMAN, mainly seen in children and younger adults, prevalent in China and Mexico, may follow a seasonal pattern, generally rapid recovery and associated with anti-GD1A antibodies, which is axonal type and begins at motor node of Ranvier, involves macrophage activation and periaxonal macrophages with minimal lymphocytic infiltration. Degree of axonal damage can vary. Acute motor and sensory axonal neuropathy (AMSN), which is uncommon and mostly affects adults. Recovery is often slower and incomplete, uh, considered closely related to AMN axonal type, and shares a similar pathology to AMAN, but also involves sensory nerves and roots. Axonal damage tends to be more severe. Miller-Fisher syndrome, which typically affects adults and includes ophthalmoplegia of third cranial nerve, ataxia, which is sensory, areflexia, and no limb weakness. The antibody which is present is anti-GQ1B antibodies. So this antibody works against gangliosides, which are most higher concentration seen in eye muscles than in limb muscles, though thus causing no limb weakness. This could be either axonal or demyelinating. Few pathological examinations are available. Findings generally resembled a acute inflammatory demyelinating polyneuropathy. Now the clinical features. So the initial or the earliest symptom is distal paresthesia and pain. Muscle weakness which rapidly ascends from lower to upper limb, more proximal than distal, and is characteristically called the ascending symmetrical paralysis. Common complications are facial nerve palsies, which is bilateral seventh nerve palsy, bulbar weakness of cranial nerve 9, 10, and 12, where the patient can't drink, can't eat, or can't talk. Aspirational pneumonias, which can further complicate the situation. Autonomic insufficiency, which could arise from T1 to T4 fibers, which are cardiac accelerator fibers. Demyelinating of these fibers can cause a reduced heart rate and reduced BP, which could look like a neurogenic shock. This could lead to reflex vasoconstriction and thus causing wide fluctuations in BP. Other symptoms like sensory, where paresthesia with muscle pain can be seen, where the patient can say it is most like a fatigued pain, and bladder and bowel is not usually affected. Ventilatory support can be required if respiratory weakness is seen due to truncal weakness, and since this condition is progressive, it peaks within 4 weeks, and respiratory failure could be possible within hours. Examination may reveal diffuse weakness with absent deep tendon reflexes. Now we'll see the investigations where CSF analysis is to be done. Uh, in CSF analysis finding, one of the most important findings is albuminocytologic dissociation, which is a very high protein content in CSF, but the cell count is normal. No other abnormal finding is seen in the CSF. Electrophysiology is also important, where a graph is taken by nerve muscle conduction test, in which multifocal motor slowing and delayed F waves are seen. We'll discuss this in few seconds. MRI spine can be taken to rule out other causes where demyelination can be seen, and antibodies can also be tested for anti-GM1 antibodies, which is seen in 25% of the cases. Differential diagnosis is very important, as it includes other causes of neuromuscular paralysis like poliomyelitis, botulism, diphtheria, spinal cord syndromes, and myasthenia. Now, Brighton criteria for diagnosis of GB syndromes is important, where bilateral and flaccid weakness of the limb is seen, and decreased or absent deep tendon reflexes in weak limbs. So this illness is defined as a monophasic illness. That means there's only one progression and peak, and no and the disease does not occur in phases, with interval between the onset and nadir. Onset is the start of the symptom, and nadir is the peak of the weakness, is between 12 hours and 28 days, with subsequent clinical plateau. And electrophysiologic findings consistent with GBS, which will show delayed F waves and multifocal slowing, cytoalbuminogenic dissociation on CSF analysis, and absence of any other alternative diagnostics for weakness. Management. So, active management includes plasma exchange and IV immunoglobulins, which shortens ventilation duration and improves prognosis. Both are equally affected if started within 2 weeks, but IVIG completion rates are higher. Also, IVIG is very costly treatment. 80% of the patients will see full recovery in 3 to 6 months, while 4% unfortunately can face mortality. And there are chances of residual neurological disabilities. Sometimes it could be severe. Poor prognostic factors include older age, rapid deterioration to ventilation, and axonal loss on electromyography. Supportive care also is important for preventing bed sores, DVT, and monitoring of respiratory function to be done to due to because there's a risk of sudden respiratory failure. Let's see motor nerve conduction test. So in this test, electrode is placed in a muscle. Let's take abductor pollicis brevis, where compound muscle action potential or CMAP is recorded by simulating at the median nerve at wrist S1 and at elbow S2. The velocity from the elbow to the wrist is determined by measuring the distance between the two stimulating electrodes, which is D, and noting down the time the potential took to reach from S1 to S2. Now, a prolonged L1 is caused due to slower nerve conduction, which could indicate demyelinating neuropathy, and a prolonged L1 could be caused by dysfunction distally in the median nerve, like carpal tunnel syndrome. Now, when nerve stimulation happens, it actually occurs in both the directions simultaneously, which where the impulse travels both afferent and efferent. The purpose of the nerve conduction study is to record the action potential along peripheral nerves and for motor nerves into the muscle belly. The role of digital recording is that it improves the sensitivity and reproducibility of small nerve potentials. The nerve conduction velocity again is calculated by the time taken by the distance by the impulse to travel from the S1 to S2, which is this. Then interpreting the signal amplitude is if it is reduced, the amplitude is reduced, then it suggests that there are fewer functioning axons. And a slowed conduction indicates demyelination. Now there are few patterns in this, which are diffuse, which is seen in hereditary demyelinating neuropathy, then focal, which are seen in pressure palsies, and multifocal, which is seen in GBS. Compound muscle action potentials or CMAP are recorded after motor nerve stimulation. These are much larger than sensory potentials, which are usually 1 to 20 millivolts. The F wave is actually an impulse which reflects back from the anterior horn cells, thus providing information about nerve root function. So, repetitive nerve stimulations are done to check the health of the muscle, and amplitude, which a CMAP, which decreases with repetitive stimulations, indicate myasthenia gravis, and CMAP, which keeps on increasing with repeated stimulation, which it could indicate Lambert-Eaton syndrome. Now that we have seen GBS, let's talk about a very similar condition called transverse myelitis. So this disease can also present post-infection, mostly URTIs, After the usual progression is that after 2 weeks, the antibodies will be formed against spinal cord that can cause severe inflammation of the spinal cord in contrast to the segmental demyelination in GBS. The clinical features again include flaccid paraplegia, truncal paralysis, and quadriplegia. But the difference is the sensory symptom, where radicular or root type pain, which is lancinating type, where the patient describes as being stabbed or acid being poured or hot water being poured over the area, is experienced by the patient. And the sensory level can also be made out during examination. It can also cause autonomic dysfunction, and bowel and bladder will be affected, where overflow incontinence will be seen. That means when the bladder is filled over 150 ml, the and it will keep on increasing and increasing, the patient will not be able to feel the bladder, and the bladder will empty itself, which is also the term for autonomic bladder. And the emptying will not be full, so post voidal residual urine will also be seen. In this condition, MRI could be the investigation of choice, because demyelinating is suspected to be seen in this condition. So, to sum up everything together, we will look at the differentials for the common common conditions causing paralysis. As GBS, we have seen completely. We'll make it a contrast with transverse myelitis, where the pain, especially the sensory involvement, is mild with paresthesia and no sensory level demarcation. But in transverse myelitis, is present with lancinating type of pain, and the bowel and bladder incontinence being present in transverse myelitis. In poliomyelitis, WBC counts are high, and protein counts are elevated compared to albuminocytologic dissociation, which is seen in GBS. While in botulinum, the toxins which are present are uh, usually at the diagnostic investigation of choice. So that sums up the topic of Guillain-Barré syndrome. If you have any doubts, feel free to ask, and thanks for watching.